The prostate cancer part 11, non-randomized trial comparing curative treatment. Non-randomized trial are inherently based on are utilized to generate hypotheses, not to prove hypotheses. The information in this section should be interpreted with this limitation in mind. Clinical practice should be based on the prospective randomized trial whenever possible. With more than 10 years of follow-up, many randomized trial studies suggest that radical prostatectomy has higher long-term curative rate, disease-specific survival, and overall survival compared to the radiation and androgen therapy, primary androgen deprivations, or surveillance. So the radical prostatectomy have a good outcome. However, radiation and brachytherapy achieve a similar overall and disease-specific survival as radical prostatectomy. Radiation, at dose of 79 to 81 gray appear to have equivalent survival compared to the radiation and brachytherapy. A few selected examples of this study are listed below. A meta-analysis by Wells at 2016 pooled 803 patients from 19 studies and found radiation alone or brachytherapy alone had a similar higher overall mortality and prostate cancer-specific mortality than radical prostatectomy. Caveats: some studies included in this meta-analysis use radiation regimens that is considered suboptimal by concurrent standard, example dose less than 75 gray, no ADT or androgen deprivation therapy for intermediate risk or high risk cancer. Robinson's 2018 compared overall 41,000 men in Swedish database who underwent radical prostatectomy or radiation. In men with low or intermediate risk disease, radiation was associated with higher rate of death from the prostate cancer that have radical prostatectomy. Also, the absolute difference was small. Bocala and Menon, 2009 or 2009 compared 6,096 men aged less than 50 years showed that the radical prostatectomy result in significantly higher 15 years cancer-specific and overall survival than either radiation or no curable therapy, especially in men with moderately or poorly differentiated tumors. This data suggests that radical prostatectomy is treatment of choice for men aged less than 50. Abdurrahman 2019 compared 3,090 or 953 prostate men who have diagnosed with localized prostate cancer during the participation in the block of screening trial and subsequently receive either radiation with or without androgen deprivations or radical prostatectomy. Men who underwent radical prostatectomy had significantly higher overall survival and had prostate cancer specific survival. Hongans 2019 compared 2,228 men with age less than 60 years and with localized lesion score more than 8 prostate cancer who underwent either radical prostatectomy with or without adjuvant radiation, radiation with or without androgen deprivative therapy, or combined radiation and brachytherapy with or without androgen deprivation therapy. Prostate cancer-specific mortality and overall mortality were higher in radiation than for radical prostatectomy, but similar for radiation and external beam radiation and plus brachytherapy. Westovers Italy 2012 compared 657 men with localized Gleason score 8 prostate cancer who underwent either radical prostatectomy or combined therapy plus brachytherapy plus ADT. There was no difference in the prostate cancer specific mortality between radical prostatectomy and combined radiation plus brachytherapy plus ADT. Mulder's 2019 compared 643 men with lesion 9 or 10 localized prostate cancer who underwent radical prostatectomy with adjuvant radiation or radiation plus brachytherapy. There was no difference in overall survival or prostate cancer mortality between the groups. Machines Italy 2012 or 2012 analyzed 12,745 men with high risk of prostate cancer who underwent brachytherapy, external beam radiation, or both. Men who underwent brachytherapy with external beam radiation had lower prostate cancer specific mortality than men underwent radiation alone. This study did not account for radiation dose. However, Amani A or Emni ATR 2016 or 2016 show no difference in overall survival with radiation at 79 to 89 gray compared to combination of radiation brachytherapy. Summary of randomized trial comparing curative treatment. Treatment with radical prostatectomy or radiation can reduce the risk of death from the prostate cancer and death from any cause compared to surveillance or watchful waiting. And these benefits are most pronounced in men aged less than 65 years. Treatment also reduces local progression, distant metastasis, and use of androgen deprivation, but it also increases the risk of side effects. Radiation and radical prostatectomy appear to achieve similar cure rates. Radical prostatectomy has higher risk of erectile dysfunction and urinary incontinence than radiation, whereas radiation has a higher risk of bowel dysfunction than radical prostatectomy. Cryotherapy has poor efficiency in high risk localized prostate cancer. Cryotherapy has significantly higher risk of erectile dysfunction than radiation, where urinary and bowel side effects are similar to radiation. It is unclear if combining radiation and brachytherapy is better. Radiation alone in men with intermediate or high risk localized prostate cancer. Surveillance and watchful and waiting versus radical prostatectomy. Watchful and waiting and active surveillance. Everson study and Bokar study compare watchful and waiting to radical prostatectomy. There was no difference in overall survival after 15 to 23 years of the follow-up. CAVED patients were enrolled between 1980, thus the data are not applicable to current practice because contemporary diagnosis and staging are different than those studies. This study were conducted before BSA was available. Also, the study population were rather small. SBCG4, Scandinavian prostate cancer group 4, compare radical prostatectomy to overall to watchful waitings in 695 men with age less than 75, PSA 50, in clinical stage T1 to T2 in 0M0, 100% of men in the radical prostatectomy group underwent retroperitoneal dissection. For the watchful waiting groups, only palliative non-curative treatment was planned. Also, 15% eventually underwent curative therapy. Androgen deprivation was administered at the time of the metastasis in both groups for men undergoing radical prostatectomy and region deprivative therapy was also initiated for bulbable local recurrence during most of the study periods. At a median follow-up of 23.6 years, men undergoing radical prostatectomy has significantly lower rates of distant metastases, 27% versus 48% deaths from prostate cancer death rate, 21% versus 35%, and deaths from any cause, 79% versus 94%. When the patient were stratified by age, radical prostatectomy had significantly lower the rate of distant metastases and deaths from the prostate cancer. Regardless of the age randomizations, also the benefit was more pronounced in men less than 65. Deaths from any cause was lower in men undergoing radical prostatectomy regardless of the age randomization, but the difference was significant only in men age less than 65. Radical prostatectomy in a mean of 2.9 years of life gain compared to surveillance. Watchful waiting had a significantly higher risk of local progression, distant metastasis, and use of androgen deprivations, but a lower risk of erectile dysfunction and urinary incontinence compared to radical prostatectomy. Conveys this study might not be applicable to curative practice because it is cohort 76% clinician stage 2, 47% BSA 10, and 5% detected by BSA is not typical of the contemporary patients. Private prostate cancer intervention versus observation trial. We'll continue here. Compared watchful waiting to radical prostatectomy in 731 men with age less than or equal 75, PSA less than 50 or equal 50, and clinical stage T1, T2, T2, and XMX. 82% of the men in the radical prostatectomy underwent retrograde lymph node dissection. For the watchful waiting groups, only palliative, non-curative treatment was planned. Also, 20% eventually underwent curative therapy. For both group, androgen deprivation was start symptomatic or metastatic progression or at the discrimination of treating physicians. At median follow-up of 18.6 years, men who underwent radical prostatectomy had significantly lower rate of deaths from any cause. Also, the absolute benefits was small, 67.6% versus 73.3%. For radical prostatectomy, survival benefits was greater in men with any of the following characteristics. If age less than 65% and 65 years, fewer comorbidities, more than or equal 34% of the core positive or intermediate risk disease. All these have benefit survival for radical prostatectomy. In most recent data, death from prostate cancer could not assist, but an older report showed that radical prostatectomy result in non-significant reduction in deaths from the prostate cancer at the median follow-up of 12.7 years, 7.4% versus 11.4%. Radical prostatectomy result in a mean of 1 year of life gained compared to the watchful and wait. So it is 1 year compared with watchful and waiting. Watchful and waiting had higher risk of local progression, bone metastasis, and use of androgen deprivation therapy, but the lower risk of erectile dysfunction and urinary incontinence compared to the radical prostatectomy compared pivot is applicable to concurrent practice because contemporary patients are similar to those studies. The majority were clinical stage T1C, BSA less than 10 detected by BSA. Pivot may not be applicable to men age less than 60. Only 10% of the patients were age less than 60. Protect trial prostate testing for cancer and treatment, randomized men with age 50 to 69, clinically localized prostate cancer, BSA 3 to 20 to radiation, active surveillance, median follow-up was 10 years. In the radical prostatectomy group, a retrograde lymph node was performed in men who had high risk of regional nodes metastasis. The proportion of the men was not reported. In the active surveillance group, curative treatment was offered. This discretions of the threatening physicians. The decision to proceed within the curative therapy was usually driven by a rise in the PSA and was not necessarily driven by cancer progression. At the median follow-up of the 10 years, there was no difference in deaths from the prostate cancer or deaths from any causes between radiation, radical prostatectomy, and surveillance. Surveillance resulted in a significantly higher rate of clinical progression and distant metastasis compared to the radiation, extended beam radiation, or radical prostatectomy. Surveillance results in lower risk of erectile dysfunction than extended beam radiation or radical prostatectomy. A lower rate of urinary incontinence than radical prostatectomy, a lower risk of bowel dysfunction than extended beam radiation. Caveats: the conclusion of this study cannot be extrapolated to men with intermediate or high risk disease because this group were underrepresented. Only 20% had Gleason score equal 7 and 2% had Gleason score more than or equal 8. The majority of this study population were low risk. Thus, they were few deaths from prostate cancer during the 10 years of the follow-up. A small number of the deaths made it difficult to determine any difference in mortality between the study arms. In SPCG 4, above the watchful waiting arm received palliative non-curative treatment for progression, where the active surveillance arm in protected received curative therapy at the discretion of the treating physician. In fact, among men assigned to the active surveillance group, treatment with curative intent was administered to 25% within 3 years and to approximately 55% by 10 years after randomization. So PROTECT did not compare curative treatment to no curative treatment. Also, 22% of men that were randomized did not undergo their assigned management. If the data are analyzed based on the treatment actually received rather than by intention to treat, the treatment within either radiation or radical prostatectomy result in the significantly lower risk of death from prostate cancer compared to active surveillance. The main message of this study appeared to be that men with low or intermediate risk prostate cancer have a small risk of dying within 10 years, whether they undergo upfront curative treatment or upfront active surveillance. Longer follow-up will be required to determine if treatment is better than surveillance or if there is a difference in survival between radiation and radical prostatectomy. A study enrolling a substance portions of intermediate and high risk men will be required to determine if treatment is better than surveillance in these groups. Taken pathology, this data suggests the radical prostatectomy reduce the local progression, distant metastasis, use of androgen deprivation, and death from prostate cancer and death from any cause compared to the watchful waitings. and these benefits are most pronounced in men less than 69 years old. Radical prostatectomy increases the risk of erectile dysfunction and urinary incontinence starting early in the course of treatment. For low-risk prostate cancer, radical prostatectomy and external beam radiation and active surveillance with possible delay curative treatment have a similar survival at 10 years of follow-up. This is a comparison of Pivot's SBCG4 and Protect. And this is the clinical state T1A, T1C, T2, and this is a PSA in all less than 10, 10 to 19, 20 to 50, and mean, and this is a biopsy, Gleason score less than or equal 6, 7, 8 to 10, mean age. And as you see here, the Pivot cancer detected by PSA 76%, and in protected cancer detected by PSA is 100%. So the management are not initially treated. That's watchful and white in both Pivot and BCG4 and active surveillance in Protect. This is management of R not initially treated. So this is a comparison between these three studies. Thank you.